Yeah. So
I'll just
the chairpersons and the moderators, uh, this endocrine intervention in carcinoma of breast and carcinoma of prostate is not very much interfered by the endocrinologist. Reason being that the patients are actually not referred to us for endocrine therapy because that part is covered by the endocrine surgeon most of the time. And now the Dr. T.P. Sahu is here, who is an oncologist. So they are also dealing with the case. So I think there is some coordination is required between endocrinologist and the treating surgeon or a endocrine, the physicians, because endocrine gland as such has got much to do with the cancer gland also, as the Dr. Abhyuday Verma has said that the diabetic patients do have a very significant level of carcinoma breast, may not be the carcinoma prostate. So first presentation is on carcinoma breast. We know that estrogen is very important for the development of breast as well as the driving force behind the carcinoma breast. So circulating and estrogens, that is basically 17-D estradiol or E2, that binds to the receptor in the breast cancer cell. And next slide, please. So that leads to the process of cell cycle progression and tumor growth. So this estrogen receptor acts in at least 4 different ways. Next slide, please. So number one is the binding with the estrogen receptor, which is at the nuclear level, and other is the growth factor binding, other is ligand free binding, and fourth is directly approaching through the ATK pathways. So foundation stone of corner practice of this was laid in 19th century when George Beatson, who found that removal of the ovaries, oophorectomy, improved the outcome of the women with advanced breast cancer. That was the basic of it. Next, please. So here we can see the mechanism. Next slide, please. Mechanism in which this is the endocrine receptor where amplification in breast cancer 1 protein is there, and that leads to transcription factors, messenger RNA, and protein formation, and therefore the cell formation. This is at the promoter gene level, and that can be without the estrogen receptor also, directly amplifying at the level of amplifying factor 1 and then binding with the estrogen receptor, and then the transcription takes place. Next, please. So right drug for right patient is very much important, and today's endocrine therapy is doing just a surgery and then putting the patient on tamoxifen. Some doctors put on tamoxifen in premenopausal as well as postmenopausal patients, but we have to look into the details of it, that where the tamoxifen and where the aromatase inhibitors should be prescribed. And clinical challenge is to put right drug in right combination to the right patient and at the right time of therapy should be given. The aim of the individual patient is to gain maximum benefit out of the endocrine therapy without incurring excessive toxicity of the drug, but because these drugs are not without toxicity. So androgen deprivation therapy using aromatase inhibitors and then blocking the estrogen receptors, the selective estrogen receptor modulators or downregulators or degraders, that are SERMs and SERDs are there. Hormonal manipulation may also be achieved with surgery and radiotherapy. So different sort of newer versions of carcinoma breast therapy is coming, and choice of endocrine therapy is given to the clinical context of the age of the patient, menopausal status of the patient, comorbidities, drug toxicity profile, and a balance between the efficacy and tolerability and toxicity of the drug. Next, please. what happens that the cancer patients are a little neglected in our society. I'm not talking about a person before Dr. T.P. Sahu, because endocrine, uh, this oncology is very important field. So this is the main drug which is available with the most of the patient being prescribed is tamoxifen, where tamoxifen bonds with the estrogen receptor, a dimer is formed, and that dimer acts on the estrogen receptor on the nucleus, and that causes transcription. Next, please. So after tamoxifen, we should know it that it is used as single agent for both pre and postmenopausal patient. Whatever prescription comes to us because of the patient has comorbid diabetes or some other factor, when they come to the endocrinologist, we know that the patient is on tamoxifen, and we don't dare to interfere the therapy of the tamoxifen. In the whether it is premenopausal and postmenopausal, both are given tamoxifen. So we have to see whether we can give tamoxifen to postmenopausal patient as well. So in breast cancer issue, tamoxifen bound estrogen receptor bound to the same genomic binding site as estrogen binding site, and there is a interaction, and tamoxifen leads to the regulation of the transcription protein to the opposite direction, and therefore there is reduction of the cell proliferation. That is the mechanism of action. Next, please. So here we can see that the estrogen receptors are there. They can activate with the epidermal growth factors, and they can directly act at the nucleus, and they can act by the HERS2, that is the human epidermal factor 2, epidermal growth factor HERS2, and in MAP or AKT or protein kinase B chain. So there are multiple mechanisms of action, and drugs are evolved to interfere with these receptors and these factors. Next, please. So tamoxifen, which is a good drug for premenopausal patient with carcinoma breast after the surgery, it is also has got opposite action on the endometrium. So in the endometrium, the estrogen transcription complex, when it is blocked, then it can lead to baseline risk of developing endometrial carcinoma by factor of 2 or 3. So we have to see the risk factor of carcinoma endometrium which can develop with tamoxifen therapy. Next, please. Then comes the aromatase inhibitors such as anastrozole, letrozole, and exemestane. Exemestane is a steroid aromatase inhibitor, and anastrozole and letrozole, we know that that is in practice of therapy in infertility and all, and they have become a preferred choice over tamoxifen. How? Because aromatase inhibitors decrease the peripheral conversion of androgen to estrogen, thereby cutting the tumor's fuel supply. And anastrozole and letrozole are non-steroidal, as I said, and there's a research incomplete cross-resistance between steroidal and non-steroidal aromatase inhibitor. Switching from anastrozole to letrozole to aromatase or vice versa may change to the disease response or toxicity. So this is that trick we have not developed yet. It is in the stage of experimentation. Then here we discuss fulvestrant, which is a selective androgen down regulator or degrader, which is a neo drug. Like tamoxifen, it actively acts at the estrogen receptor but has a distinct mechanism of action. Once bound, fulvestrant leads to the ER degradation and loss of ER protein expression, which has been shown to be dose dependent, and no known agonist activity, and therefore from the endometrial carcinoma there is a escape that will not develop, and prothrombotic and pro-proliferative side effects of tamoxifen can also be avoided. Tamoxifen can have some prothrombotic tendency. In contrast to AIs, which are known to be deleterious to the bone mineral density, fulvestrant is safe for the bone mineral density and does not reduce it. Here we can see a study in which the fulvestrant and the comparison with the tamoxifen, a 250 milligram dose of fluoxetine, which is a SERD, down regulator of the estrogen receptor, caused significant reduction in the level of the estrogen receptor expression. Next, please. And newer drugs are coming, mTORs and the CKD4/6 inhibitors, and they are at the evolving phase. Next, please. The blockade of the growth factor receptor signaling pathway to overcome tamoxifen resistance. Sometimes we face with tamoxifen resistance, and that is not investigated in routine practice of carcinoma breast patients. So the estrogen receptor calculation and tamoxifen bound can have activation of the epidermal growth factor, and this epidermal growth factor activation causes tamoxifen resistance. This part should be kept in mind because the mitogen activated protein kinase or AKT or protein kinase B, estrogen alpha, receptor alpha, and amplified in breast cancer, all these things restore tamoxifen antagonist activity on the tumor growth. So the tamoxifen resistance is very important pathway, and that has to be checked by giving epidermal growth factor antagonist. So newer drugs like rapamycin, which acts by threonine serine kinase downstream by PI3K, that is phosphatidylinosytol 3 kinase, and AKT, that is protein kinase B, and that cross-link is a pathway of evolving field in case of endocrinology of the breast cancer. mTOR inhibition is claimed to have an indirect but specific effect on the estrogen receptor activity. Next, please. So in the case of advanced breast cancer, when it is non-curative, it has already spread and metastatized, then endocrine therapy is the only choice we have. And response to endocrine therapy in the advanced setting is assessed with the established objective assessment criteria such as response evaluation criteria of solid tumors, the RECIST, and UICC. They are different criteria which are better known to an oncologist. Next, please. So clinical benefit and a key principle of the endocrine therapy, decision making in advanced ER plus disease. Whether endocrinology should be involved or not, that has not come in national platform very clearly, and that part is dominated by the surgeons who is treating it, basically the oncosurgeon or breast surgeon. Patient will be commenced on the best agent first, and after 6 months of treatment, the patient who have stable disease, have got cervical advantage, and who achieved the objective response. These are the definite criteria that better known to the onco people compared to those have progressive disease. Patient with observed response and the stable disease after 6 months should be considered, and they should have a change in therapy in the direction of the endocrinology and estrogen receptor pathway. Next, please. Patient who present with advanced ER disease and can now a new patient or pre-existing breast cancer patient whose disease has relapsed, a failure of the adjuvant treatment, initial therapy for the advanced disease is based upon prior use of endocrine therapy in the adjuvant setting. The clinical focus of treatment in the non-curative setting is on quality of life, and therefore endocrine therapy being efficacious and generally well tolerated is therefore the default treatment, and fluoxetine is usually used the SERD in those patients. Next, please. A premenopausal patient with advanced ER disease, the GnRH agonist therapy can be used in first line to suppress the ovarian production of the estrogen. Goserelin is used in combination with tamoxifen, and provided tamoxifen has not previously used in adjuvant setting, and there is no evidence that GnRH agonist therapy in combination with the aromatase inhibitor works clinically and biochemically better than tamoxifen and GnRH agonist therapy. Next, please. In postmenopausal, which is advanced ER disease, the third generation AI should be given, but in most of the prescription I see tamoxifen only, and whether it is superior or not, Dr. Sahu will be able to and tell us something. As an example, direct comparison between tamoxifen showed with anastrozole does not show a median time of progression by 4 months. Next, please. The targeted drugs are there as CKD4/6 and mTOR inhibitors. These drugs options are coming up, and newer drugs are coming as pelbociclib, and other two ciclips are also there. Next, please. So combination therapy with aromatase inhibitors and CKD4/6 inhibitors has been standard first-line endocrine therapy in metastatic hormone receptor positive breast cancer, and the palbociclib, ribociclib, and abemaciclib are the newer drugs which are coming. Next. So where combination therapy is not an option, the fluorescent is a 500 milligram is a sole therapy in advanced disease when nothing can be done, and trial of fluorescent used in first line advanced ER plus breast cancer included the first phase, the first trial and Falcon trial, and the Falcon 3 trial demonstrated superiority of the fluorescent over the anastrozole therapy. Next, please. So combination of fluorescent and aromatase inhibition has also been explored in the clinical data, but that is called as maximum endocrine therapy. However, additional benefit of combination versus single agent therapy is difficult to demonstrate. So in patient with hormone receptor positive disease with an overexpressed HER2, that is epidermal growth factor 2, targeted therapy can be used either sequentially or in combination. Comparison of these approaches was made in the tandem studies, which reported that trastuzumab plus anastrozole improved progression-free survival. Trastuzumab is an epidermal growth factor antagonist and the AI combination. So patient with hormone curative setting, endocrine therapy is given and adjuvant therapy up to 10 years. So 10 years time is important, followed by definite surgery, reduce the risk of disease recurrence or relapse in patient with the ER plus breast cancer. Additional chemotherapy is sometimes given, and nowadays chemotherapy is given first, then the surgery is done, and then the patient is put on the endocrine therapy, depending upon the Nottingham Prognostics Index and clinical risk stratification tool as Oncotype DX. Next, please. The choice of endocrine therapy drug in the adjuvant setting depends primarily on the menopausal state, and tamoxifen as an adjuvant, it depends upon the science, and I'm not in a position to tell exactly what should be done. Premenopausal women whom levels of circulating estrogen are higher, then both the ovaries can be removed and tamoxifen can be given. Next, please. In postmenopausal women, the aromatase enzyme inhibitors will be a better choice. Next. Important concern is with us is bone mineral density, and estrogen inhibitors will have a checked BMD. Of course, the calcium, vitamin D has to be given in those patients over bisphosphonate medication. So AI drugs conjugate trials with tamoxifen with aromatase inhibitors simultaneously, sometimes interchange drugs and sequential trials, and then switchover trials and extended adjuvant trials are all available there. Next, please. And then non-adjuvant endocrine therapy, new non-adjuvant therapy with can downstage the tumor with chemotherapy can also be given with the surgery, as I discussed previously. Next, please. So it is possible to get endocrine therapy in a perioperative, and we should be concerned about the venous thromboembolism part. Next, please. This is the estrogen status of the primary breast cancer by age, but in different trials. But we can see that the age group of about 40-45 has got maximum estrogen receptor expression. Next, please. Chemoprevention trials has undergone, whether breast cancer can be prevented. The cancer trialist collaborative group study early breast cancer meta-analysis has said that breast cancer can be reduced from 4.7% to 2.6%. And role of tamoxifen in this prevention of the breast cancer is not fully evolved. Next, please. So to conclude, endocrine therapy is the mainstay of treatment of ER-positive breast cancer. Novel therapies are coming to the field like mTOR inhibitors and the CKD4/6 inhibitors. Next, in the older population who have compromised the majority of the breast cancer patient, such development may help to redefine the role of primary endocrine therapy. In younger patients, high-risk breast cancer, the role of chemoprevention is likely to expand, and endocrine treatment failure resistance is likely to have a substantial impact on future clinical practice. Only biomarkers to select patients for endocrine therapy is expression of the transcription factor, that is estrogen receptor transcription factors, and further laboratory analysis is required. Then I come to the prostate cancer, the two cancers where endocrinologists can. It is a androgen dependent condition where the DHE, dihydrotestosterone, promotes the growth of neoplastic tissue. Androgen deprivation has been the mainstay of therapy, which can be achieved with surgical or medical means. And types of medical regimes are intermittent maximum or sequential androgen blockade. So if you go in the history of prostate cancer, next slide please. American surgeon Charles Brenton Higgins, and classical work has shown that when the androgen deprivation was used by gastrectomy, then the patient has a benefit in the breast cancer therapy. Prostate cancer therapy. So castration remains a mainstay. The surgical orchidectomy or medical orchidectomy with GnRH agonists are the mainstay of therapy. 94% of the cancer prostate do respond to the androgen deprivation, and the 5-year survival is very high. Of course, the ill effect of sustained initial response of blockade of androgen secretion of action can be there, and tumor can regrow later on. So there are castration-resistant prostate cancers. Next, please. So this is the mechanism where hypothalamus and pituitary, the LHRH and LH, CTH, adrenal glands contribute to about 5%, and testosterone contribute maximum 95% of the testosterone. These testosterone act on the nucleus. They act also on the cytoplasm. They are carried to the nucleus, and that is the way it acts. Next, please. So there can be different types of prostate cancer. There can be clinically localized cancer, which can be watched carefully. There can be radical prostatectomy. There can be radiation with the adjuvant medical orchidectomy. There can be a recurrence and medical surgical orchidectomy can be done, or there can be locally advanced metastatic cancer where medical or surgical orchidectomy with recurrence, anti-androgen, with recurrence, anti-androgen withdrawal, and secondary hormonal therapies can be done. So next slide, please. So important is 5-alpha reductase. 5-alpha reductase inhibitors are the mainstay of therapy, as finasteride and dutasteride can be used as a prostate cancer prevention trial. They are preventive trial. Next, please. So dutasteride is a drug which has got advantage from finasteride because it is a better chemoprotective effect. And in one trial, the reduced trial, dutasteride reduction of the dutasteride prostate cancer events, the rate of biopsy-detected prostate cancer compared were low. And as compared to the non-treated patient. Next, please. So for fundamental of prostate cancer, the low risk cancer is tumor 1 and 2. The Gleason score is the microscopic score, histopathological score, and PSA levels are the low risk patient, PSA less than 10. Intermediate risk is PSA between 10 to 20. Gleason score less than 7 or 2B or 2C. patients are the intermediate risk and high risk are a tumor grade 3 and Gleason score of 8 to 10 or PSA more than 20, and metastatic disease and locally advanced disease. This is the fundamental of prostate cancer, what we should know. And there are different drugs, GnRH agonists, the GnRH antagonist, aberralex and degarelix, anti-androgen frutamide is the main drug which is available, and adrenal androgen inhibitors, ketoconazole, corticosteroid, aminoglutathione, and estrogen were tried initially, and that also gave some results. The dihydrosterol, the estradiol, and different drugs are available. Next, please. So basically, GnRH agonist, which is used presently in prostate cancer, they reduce the secretion of testosterone. The goserelin, leuprorelin, goserelin, and tritorelin are administered in deep preparation, and the target is to keep the testosterone level less than 50 nanogram per ml. Next, please. The side effect of the anti-androgen therapy, we should keep in mind that anemia, the cholesterol disorders, the cognitive dysfunctions, depression, edema, erectile dysfunction, fatigue, glucose, insulin changes, and hair loss, hot flashes, libido changes, muscle joint pain, osteoporosis, and thyroid hormone level reduction. That all can happen with anti-androgen therapy. And approach to the endocrine manipulation can be intermittent androgen deprivation, it can be maximum androgen deprivation, and sequential androgen deprivation. So androgen blockade for a period of 6 to 9 months, GnRH agonist withheld once PSA nadir is achieved, and maximum androgen blockade when we have to block the androgen with the adrenal steroids are blocked, and the steroids of adrenal origin led to the belief that the development of the castration-resistant prostate cancer was caused by adrenal androgen. So maximum androgen blockade is advised in those patients where we suspect that not only the testicles which have been removed or has been nullified, the adrenal androgen still can cause the growth of the cancer cells. So GnRH agonist has been used with the anti-androgens in sequential pattern also. Next, please. In metastatic prostate cancer, where nothing can be done and improvement of 5-year survival is low, there the sequential androgen blockade can be there, and in the relapse cases, medical and surgical orchidectomy relapse is there, then we have to give empirical therapy. Next, please. So anti-androgen therapy in combination of surgery, new adjuvant therapy has been tried, in which when the prostatectomy reduces the prostate size with new adjuvant therapy given for 3 months, and if no advantage with the new adjuvant therapy is seen, both in recurrence rate and reduction of the complication of radical prostatectomy, the studies have shown there is no difference in the adjuvant therapy and prostatectomy. Next, please. In metastatic cancer of the prostate, adjuvant therapy are the success, in which we have to give the aromatase inhibitors and fluoxetine, which are drugs available. Next, please. So this is the again same parameters where we can go advanced. Next. Radiotherapy. Presently, the radiotherapy is done to the patient when the prostate cancer is quite advanced, and then after irradiation, when the localization of the cancer is there, then the surgical therapy can be done, and then followed by the adrenal adjuvant therapy. Next, please. Timing of hormone therapy. It is a debated topic whether immediately we should start or it should be delayed. The ambiguity prevails in different trials, and the trials are not very clear, especially in metastatic and as well as localized lesions, high volume, high grade or lymph node positive diseases. What is superior, primarily the hormone therapy or delayed hormone therapy. The trials are going on and the situation is not very clear. Next, please. So to conclude, that endocrine manipulation has an important role of play in cancer prostate despite many areas pertaining to needing clarification. Aromatase inhibitors are the reduce the risk but do not eliminate it, and adjuvant drug therapy in the form of surgical or medical castration with estrogen, GnRH agonist and antagonist, an effective therapy for locally advanced and metastatic disease. Next, please. So anti-androgen, especially bicalutamide, has been tested as monotherapy but proven less effective. Only drug which are having is flutamide in India, as I suppose. Adjuvant hormonal therapy with surgery and radiotherapy is a good approach and has got a survival benefit. The data favors use of early anti-androgen drugs in both metastatic and disease and advanced disease. Finally, the challenge in the future is to develop means to prevent the treatment of the castration-resistant prostate cancer. Novel drugs such as new anti-androgen like MDV3100, an inhibitor of androgen synthesis, abiraterone, are under trial. Thank you.